Hey everyone, thanks for joining us today and welcome to our webinar on leveraging HCCs to improve care. This is part 3 in our data-driven analytics webinar series that we have been holding through the end of this year. My name is Scott Everett. I'm the Vice President of Healthcare Solutions with Practical Data Solutions, and I'm excited today to be joined by Kelly Constantinidis, one of our Senior Business Intelligence Analysts. Welcome, Kelly.
Hey, thanks, Scott, and thank you to everyone for joining us today.
It's a big trend in healthcare today where organizations are using predictive analytics and complex algorithms and big data and going through and finding who are the patients who are at the highest risk of adverse outcomes, of getting sicker, of increased costs. And we're not going to talk about that today. We want to talk about something that's a little bit easier to do, but ways that we can be a little bit more proactive in our approach, because what we're really worried about is how can we become more data-driven in our treatment of Bob? And for those of you who have been with us for a while, you know that Bob is kind of our standard patient that we like to use as an example when talking about chronic conditions. But really, finding Bob and treating Bob is a key in providing overall quality care.
Right, Scott, but Bob is just one of our patients. We really need to understand that entire patient population. Many of our patients will be healthy. They will, just need those annual wellness checkups and sometimes need treatment for an acute condition. But some of our patients will have at least one of those chronic conditions that you just talked about. And, those are the patients at risk requiring a higher level of care potentially.
Yeah, so I think really what we want to look at is ways that we can stratify our populations. And again, it doesn't have to be a super complex algorithm out there. We can utilize what's been put in place for value-based care for HCC risk scoring. And what we can do is we can take this population, and whether they're on a value-based care plan or not, we can understand our entire population by looking at these HCC conditions.
Yeah, so Scott, HCCs aren't just for value-based care or Medicare. Not necessarily just for primary care and reimbursement purposes. Can't we start to use all of this HCC scoring data to really drive patient care?
Yeah, see, keywords there: data drive, data driven. That's we want to utilize all of the data that we have to become a data-driven organization. And what you've been seeing on all of these webinars that we've been doing is, what's it really mean to be data-driven? You can't go anywhere in healthcare these days without hearing the words being data-driven. But what do we really mean by that? And what we mean is we're trying to overcome personal biases and let the data tell us what's going on in the practice. We need to balance perspectives. We want to take what we're seeing from the data. We want to uncover opportunities or gaps. And then we want to utilize what we're seeing to improve performance. And then, of course, make it a cycle. Once we put something in place, we want to evaluate if we've done a good job with it. And that can extend to the way that we provide care.
And as we talk about HCCs and patient risk, it's really about being able to identify specific gaps with our patients like Bob. We need to, have that good reporting to identify and be able to close those gaps on an ongoing basis.
So let's take a quick look at a potential visual that you could utilize for HCC risk scoring. And really, when you look at this is kind of a high-level summary where you could take the information that you have and you could identify your highest and moderate risk patients. You can find where there may be gaps for conditions that we haven't scored for this year that we've seen in prior years. We can look at the different conditions that are being treated by our providers. But again, I think in the end, what we need to do is understand what these really mean. Every single one of those dots right there isn't a dot, it's a person. And so what we want to do is get back to understanding Bob. So let's take a look at Bob himself. Bob's a 78-year-old male. Bob lives in Florida. He's got diabetes. He's obese. He has congestive heart failure. These are all conditions that we're working with Bob on. Now, we know all of those conditions. Those are in the medical record, but how can we quantify that, and what can we do to help understand the risks that Bob has?
Sure. So, Scott, Bob gets a demographic score, and this is based on CMS age and gender score, and that score will increase as Bob gets older. Bob has diagnoses that map to 3 HCC conditions based on the CMS HCC tables. And each of those HCCs or conditions has a different value, and it's based on the severity of that condition. CMS also provides for an interaction score for certain conditions. And, Bob may not have that high of a score compared to other patients, but we can take our diagnoses and visit data and score all of our patients, regardless of how old they are and regardless of the payer.
Yeah, now these numbers actually do mean something, and they were put into place for value-based care from a reimbursement standpoint. So when we look at it, it was used as a multiplier in Medicare Advantage plans for reimbursement for capitated payments, or it's utilized in shared savings plans for to factor in for cost benchmarks for ACOs that they're working with on shared savings plan or bundled payments. That can be utilized for a multiplier in that as well. So really what these numbers were set up for was to identify the potential risk for higher cost that these patients would come up with. So if we look at Bob's risk adjustment score, you take it by the benchmark of the county that he lives in, and you can see what would be allocated for Bob from a cost of care standpoint for a reimbursement in a value-based contract.
Right, but we're not going to talk about that today, Scott. We are focused on using that HCC scoring to help drive patient care. And what we're talking about, assigning a risk score to all of our patients so that we can see if they fit into the healthy category or if they have one or more of those conditions that make them low, moderate, or higher risk.
Yeah, and we talk about utilizing it for our not just value-based care, but fee-for-service as well. The reason value-based care uses this is because they found that if you can work with patients in a certain way, then it helps to mitigate the costs and improve the care and outcomes that they get. And if that's the case, why wouldn't we do that for all of our patients? It's the right thing to do. And really, if you think about it, even with your fee-for-service patients, if you're providing better services, if you're providing appropriate follow-up care with them, not only are you going to improve outcomes and improve quality and improve patient satisfaction, you're going to see a financial benefit that stems from that as well. I think the problem that we're seeing with this, though, Kelly, is that this data can be difficult to come by sometimes. What we found with the clients we've been working with is they're getting this data from the payers, and they're taking it back to the EHR, and it's a manual process, and it can be a fairly complex process, and they're trying to match up and reconcile this way. And the problem that you have when you do this is the insurance data that you're getting is only looking at those patients within their population. They're only looking at their subscribers, and they may only be sending you back the data that's on those subscribers in their particular value-based plan. You're not getting a complete picture just by utilizing these two data sources.
Right. And, payers are getting their information from claims data, and there are fail points throughout that process, as we all know. There are clearinghouses, claim scrubbing. Some information like diagnosis codes can get lost in that process. Are denials impacting payer data? Payers are using claims data on the patients, and are we comfortable that data on claims from other providers is accurate and complete?
Yeah, so this is a big problem that we found, Kelly, and what we found really helps kind of round out that complete picture that we're looking at is if we incorporate our billing data along with it, and we start doing the risk scoring internally, where we can look at a complete picture of the patient, because we've got a complete and accurate list of diagnosis codes. We know who the patient's primary care physician is. We have a list of our patient demographics. We know which patients have been in. We know which patients are coming in. all of this data is available to us right here. And so really, if we want to become truly data driven, we want to utilize data from all of these sources. We want to be able to take that billing data. We need to be able to round it out with what the insurance companies are telling us. We need to be able to get into the weeds with the EHR data. And so utilizing all of these sources can help us really kind of balance all of these perspectives.
Yep. And if we really want to make it a full picture, Scott, I think we should bring in the patient perspective and, look at that patient satisfaction data.
Yeah, actually, that's a great point, Kelly, that, we want to make sure that we're balancing all of these perspectives. That's truly what we're looking at in eliminating biases. And in order to do that, we need to understand what the patients are telling us as well. So one advantage to bringing in the billing data that we have is that it allows us to be a little bit more proactive in our internal risk scores, where we can go back and we can kind of reconcile with what the payers are telling us from their data. What we've found with people we've been working with is that payer inaccuracy rates are running in the 12 to 18% range. And if we have the right information from what we know is going on, we can help to overcome those fail points between where we're submitting the claims and what the payers are receiving. And we can help to reconcile that data, and that's going to be a financial benefit to the practice as well. But in order to do all of this stuff, we're going to need to really incorporate some data-driven principles. And some of the biggest ones that we're looking at for this is access to data. The right people need to have access to the right data at the right time. There needs to be an automation process for getting the data calculated and out. There needs to be a visualization process at a high level for executives and providers, but we also need to be able to get down to the detail level. And the people who need to do that really need to be self-service and get to be able to get the data that they need when they need it. And that has to be an inherent part of your culture. So Kelly, when we've been working on this, and we've spent a lot of time with this over the past year or so in meetings and discussions and solutions and development, I think we've found that there are ways to get the different levels of data and roll-ups that have been pretty effective.
Yes, Scott. So we're going to get to this data. We know that our patients come in to see a provider, and we enter the CPT or procedures that they have, as well as that diagnoses information related to the patient or the visit. And then we can leverage that the diagnoses codes along with the CMS HCC designation to create an HCC list for those patients. As part of that, we'll assign scores for each HCC, and we'll end up with a complete score for that patient. And then we can start to look at the whole population, whether we need to look at it by provider, payer, specialty. And then we can start to see what those patients have had in the past, and what we need to treat them for going forward.
Yeah, and this is important point to note, Kelly, is that all of these different roll-ups are very valuable, and different people need to see this at different times. What's, I think, really critical is being able to move from one to the other. And, once we get up even to that highest level, that we can get back down into the detail, that, we have to be able to get into that patient and encounter level detail, especially with this particular data set that we're working with. So let's get back to that visual that we looked at before. And again, when we take this information, it's even more complete when we're not just using payer data, but we're doing the internal scoring. We have all of our patients here. We see all of the conditions that we're treating. We see all of the risk levels and gaps, and we can even look at a projected revenue amount for, each individual patient that's there. But again, this is a very high level, summary level information that we're looking at. If we want to get down to that more detail level, we need to be able to do that as well pretty seamlessly.
Yep. And here we can see individual patients and what they have been treated for those specific conditions over time, and quickly see if they haven't been treated for them this year. And then we can also, see if the coefficients for those particular conditions are changing over time as well.
Yeah, and I think this really speaks to the point, Kelly, of again, different people, different data. And it talks to what we call our analytics trio. And what we mean by our analytics trio is that there's really three parts to analysis that's out there. There's the visualization piece, which is that high level. And we have a lot of clients that are utilizing Tableau or Click or Power BI to get to that visualization layer. But sometimes then you need to get more detail from that, and you need to get into an OLAP slice and dice, and they may be using a different tool like pivot tables in Microsoft Excel or something like that, or they need to get down to that detail that we just showed. If they're utilizing different tools, it can be a complex process, particularly with a data set like this that has potentially a lot of different ways to get to it, and they don't want to have to recreate queries each time they have to move to a different tool. What they want is they want a single source of truth, something that's going to help them from that visualization standpoint move into the slice and dice and into the detail reporting seamlessly, and allow people to get the data that they need to get, which again is going to be different for the different roles that each person has within the organization.
Right. So who needs what? The executives or managed care or value-based contracting teams, they may need that summary level visualization by provider, specialty, and payer. And then, we know that our clinical staff or care team needs to be able to see that patient detail and see the risk associated with those patients and those individual conditions that the patients have. And then when it comes to our provider, it would be nice for them just to see a snapshot of their patient scoring.
Yeah, so, this is an example that a provider may just need a monthly or weekly dashboard that helps them understand how well they're doing from a scoring standpoint of looking at their overall population, how many and we anticipate have chronic conditions. They can look at average risk scores, things like that. But what we're looking at here is how well they're doing in getting those patients in, getting them scored completely based upon what we know they've had in past years and what they've been diagnosed with in the current year, and making sure that they can help plan appropriate follow-up care with these patients. But, again, this is high level. It's for a provider, and what we're really aiming to do is to improve care. And in order to do that, let's get back to Bob, because we have some more information about Bob that is going to help us identify some gaps that are out there. So we talk about Bob. We know his conditions. We know his risk score, but we don't necessarily know right away. Bob hasn't been in for over 7 months. Bob's diabetic and Bob has congestive heart failure. He should be in every 3 to 4 months. Bob hasn't had an A1C test or his diabetes in over 9 months. Bob has a couple of prescriptions expiring. This might require us to bring in another data set to look at in order to help treat Bob better.
Well, and we have to consider Bob's perspective as well as it, relates to scheduling and things. Bob has indicated he struggles with the patient portal and scheduling appointments there. Like me, Bob is old school and prefers to call the office and speak with a person, not the computer. So we have some obstacles getting him scheduled for follow-up care.
So the problem that arises with this pretty quickly then, Kelly, is those patients with chronic conditions like Bob, eventually they're going to get sick. And they'll reach out to us. And if we're depending upon them solely to reach out to us to provide care, there's some urgency involved with that. Now, he's going to call us, and if we can get him in the same day, that's great. But if we can't get him in and we're like, Bob, we can get you in 5 days, we can get you in a week, that's an unacceptable answer to Bob. He's going to go somewhere else. He'll go to urgent care. He may go to a different provider. If it's bad enough, he may go to the ER, or worst case scenario, an ambulance ride, ER, inpatient stay. That's not providing the best care for Bob. That's managing Bob in a state of sickness, when really the best case we can do is we can actually be proactive with Bob and start managing him in a state of wellness.
Right. And we see some benefits from that as far as, we don't have to try to squeeze him into an already booked schedule. We can prepare him to come ready fasting to do his lab work so he can make one trip instead of two. We can, do some pre-visit work to be able to identify and flag gaps prior to him actually showing up at the practice, and then overall he should have a better experience.
Yeah, so I think what we're talking about is there's an opportunity here to be proactive and reach out to Bob to schedule him. If you think about it, when Bob's sick and we say, Bob, we can't see you for 5 days, we can't see you for a week, that's not acceptable. Bob, we haven't seen you in a while. We'd like to get you in. Can you come in 2 weeks at this time? Or Bob, can you come in 3 weeks at this time? That's perfectly acceptable to Bob. And he feels good about it because he feels like we notice him and we care about him. And when we do that, we can plug Bob in places where we have available capacity down the road rather than trying to squeeze him in an urgent situation. The urgency diminishes from scheduling. The urgency diminishes in Bob's care. We can help make sure he's compliant, get him refills on all of the medications that he's needed. Really, when you think about it, being proactive is going to really help drive better outcomes for Bob. And so as we put something like this in place, we might need to track when are the cases where we're depending on the patients to come to us rather than us going to the patients. And so we can see where the source of our appointments are, how many are coming in through the call center, how many are coming in through the online portal, how many are we calling out to the patient and scheduling, and how many times are we scheduling in clinic. If we have knowledge of the patient's conditions and we know how frequently they can come in, there's an opportunity to schedule them for follow-up care while they're still there in the clinic, like my dentist does every single time. This is something that helps to create that state of wellness that's out there. So if we're going to do that, Kelly, who are the particular patients that we should be looking out for?
Well, we want to look for patients that have not been seen for their annual wellness check within the last 12 months. For any patients with chronic conditions that need to be seen more frequently, have they not been seen in the last 3 to 6 months? We want to see if we're missing either treating for or documenting that we're treating for those chronic conditions of patients. And then we can focus in on those patients that don't have upcoming appointments. If they have an appointment coming, okay, but otherwise we might want to focus in on them.
Okay, so again, looks like we're joining in another data set coming up with that. And, a visual like this can help to create work lists. Or again, we know our patient acuity, we know our highest and high and moderate risk patients. And then we can go from there, Kelly. What else are we looking at here?
So this is, you said bringing in another data set. We are blending HCC scoring data with the scheduling data. So we can focus in, easily highlight those patients that are indeed overdue for their wellness visit. And then we can focus in, do they have an upcoming appointment? And if then that brings us to basically a work list of patients that may not have upcoming appointments. And, that becomes our focused client.
Yeah, I think this is a really useful visualization to help be a little bit more proactive in what we're doing. And really what we're doing when we bring this in is, again, utilizing all of the data that's at our fingertips. And that's the type of things that we need to do to really get to the highest levels of being a data-driven organization. We refer to it as analytical intensity, where, we can start off with those different data summarizations and roll-ups like you described before, Kelly. We can benchmark the payers again, the patients against each other as far as who is the highest risk and where to cut off those high risk, moderate risk scores to get to. And we just talked about relationships where we can bring in other data sets to help balance perspectives and help really get to, strong management that's going to help drive our care. Where if we want to get to the highest levels, we need to start looking at projections where we're bringing in predictive information. And some of the best ways we found to do this is what we call our performance opportunity metrics, where we can take measures, and there are a lot of them when we're looking at risk scoring, but this is just one where we're looking at Medicare wellness utilization and what could happen from a financial standpoint if we were to improve the level of wellness visits that we had, whether it's Medicare, whether it's physical, but getting all our patients in and getting them seen, getting their complete risk scores, understanding all of their conditions. What we found is there's a financial benefit that follows this in addition to, you know, the quality benefit. And so what we're looking at is if we can look at utilization rates, and we found that utilization rates for physical and wellness visits is below 50%. If we could get that up to a target level, or if we could get it up even to the division average or department average or clinic average of each of these providers, those providers who are below average are going to represent a significant financial benefit just by improving the level of utilization of these particular visits that are out there. And so that can be a compelling reason to change the way that they're doing things, compelling reason to look at this data and move forward. But, you know, this is just one thing where we're looking at what's going on. We're saying what could happen. And if it did happen, here's the performance gains that we would get to. So Kelly, you talked a little bit before about changes that are coming to this, and there are a lot of changes. And so I think let's illustrate this a little bit by, you know, let's bring Bob back for a minute.
In 2023, Bob's HCC has HCC 18 due to his diabetes. In 2024, he'll have HCC 37. The descriptions on several of the conditions have changed as well. The coefficient values will be changing. Some of them are significant, and the diagnoses codes that you know, Bob has today, like supports the angina HCC, that will no longer qualify for an HCC under the new HCC listing. So those are some of the highlights. It gets really fun from there.
Yeah, it's like CMS, it can't do anything easily. You know, it couldn't just change the coefficients and the mapped diagnoses. We have to change all of the numbers and descriptions too, just to make it as complicated as possible. Anyway.
So we talked today about the importance of applying the risk scoring to all patients. We can identify, regardless of their age and their payer, we can determine which patients have these chronic conditions and require care plans, visit frequency that are specific to those conditions.
Yeah, and hopefully if we've mentioned anything today that you take back is the importance of really risk scoring for everybody, not just your value-based plans, not just your Medicare Advantage patients, but look at your entire population and become proactive in the way that you serve them and schedule the follow-up care, and looking to understand how you can get them in and get them completely scored and get a true understanding of all of the conditions you're treating them on. And it becomes a cyclical process where, if you think about it, you may be in with them in a wellness visit or in follow-up care, and then another condition kind of identifies itself. That new condition is going to require additional risk stratification. It may require new care planning, more follow-up care that comes through. Maybe you know, specialty care comes into play with that. And that needs to go back to the delivery team, which again is going to make sure that we're treating these patients appropriately, receiving the appropriate follow-up care, and the cycle repeats itself. But in the end of the day, if you want to really look at it, doing the right thing for the patient and taking a patient-centered approach is going to improve our quality of care. It's going to improve those patients' outcome. It's going to make the patients have a better experience with our organization, and in the end, it's going to bring a financial benefit to the group as well. It's kind of funny how putting the patient first really makes you take care of everything else as well. So with that, I appreciate your time today and joining us for this this topic. And Kelly, thank you for joining and helping present today.
Thank you, Scott.